We decided to have this roundtable just because we think we're at a phase of the pandemic where vaccination is going to be playing a key role in helping to slow down disease transmission. Obviously, a lot of other things are still important: mask wearing, social distancing, which we can talk about with the discussants. But we thought it'd be good to discuss vaccination. And so we have 4 discussants. We have Paul Gifford, who is a professor at the UAB School of Medicine, Bertha Hidalgo, who's an associate professor in the Department of Epidemiology at the School of Public Health, Dr. Richard Kaslow, who's a professor emeritus from the Department of Epidemiology, and Dr. Mark Wilson, who is the director of the Jefferson County Department of Health. And maybe to get us started, I'm going to stop sharing my screen, but maybe each of them can briefly introduce themselves and provide just about a minute background about who they are. And then we will get started. I have some prepared questions for the discussants to get the conversation started. But once again, if other people have questions, please use the chat function. And so, Dr. Gifford, can we start with you and maybe just give a brief introduction for people who may not know you?
Hi, yes, I'm Paul Gifford. Thanks for having me. I started off as a clinician primarily, and in fact, I was actually, Dr. Mark Wilson was my attending at Cooper Green many years ago. And then I got into research as an infectious disease fellow and worked on a virus called foamy-virus, but then quickly transitioned to HIV. And actually, I worked with Dr. Kaslow, who sort of mentored me for a while, coming up and learning different research technology techniques. And then I've been involved with vaccine work since I was a fellow in 1994, primarily HIV vaccine, but also anthrax, hepatitis, HPV. And then more recently, over the past year, I've been heavily involved with the COVID vaccine effort. We've enrolled in the Sanofi study here, and then also the Janssen study, and I'm a co-chair of the Janssen global vaccine effort. And thank you for having me.
Okay, great. Well, we're looking forward to hearing some of your thoughts about the vaccine. Dr. Hidalgo, can you please provide a brief introduction?
Sure. Hi, everyone. Thank you for having me as well. I'm Bertha Dalghum, Associate Professor in Epidemiology. I'm a genetic epidemiologist, but in the last year have been intensively involved in science communication. It started out as science communication of general health topics, and it very quickly shifted to COVID-19 and really trying to disseminate and relay a lot of what we were learning in academic circles, share it in lay language on social media, such that people were understanding all of the information that was so quickly coming out in ways that we were understanding as academics and the implications of all of that. And so most recently, that communication has shifted to vaccines and vaccine hesitancy and really addressing the concerns of the community that I am in touch with on social media. And so I am happy to share some of those insights with you today.
Thank you, and thank you for joining us. I look forward to hearing what you have to say. Next is Dr. Richard Kaslow.
I was trained in infectious disease and epidemiology many years ago. I spent a few years at CDC and then 16 years at NIH doing infectious disease epidemiology. I then moved to UAB, where I spent 17 years working with Paul. A generous comment about mentorship. He taught me as much as I taught him, and worked with both infectious disease folks and in immunogenetics mainly. Then left UAB in 2012 to come back to Washington, where we had been, and spent 5 years at the central headquarters of the Veterans Administration, Department of Veterans Affairs. and led the public health office there in a variety of things, including the Ebola and Zika outbreaks as well. Then I retired from the VA in 2016 and have been spending my time enjoying myself until COVID hit, of course. And I'm trying to stay a little involved and active in the work that we've been doing, and now in COVID, of course.
Thank you very much for joining us. It's great to see you again and look forward to hearing your thoughts. And then our final discussant is Dr. Mark Wilson.
Hi, everybody. I'm Dr. Mark Wilson. I'm the county health officer and head of the Jefferson County Department of Health. My original background is in general internal medicine. I was at the Cooper Green Hospital for about 20 years, primary care and inpatient teaching service, medical director of clinics, chief of staff for a while. Sort of evolved into public health just because of my interest mainly in the underserved community in Birmingham area, and starting to do some advocacy and policy work. Came on the Board of Health and then was chosen to be health officer back in 2011. And yes, I was Paul Gifford's attending, but I was a pretty young attending, and he was definitely smarter than I and taught me a lot more than I taught him.
And I'm going to get us started. And since Mark, I see you, and this could be a question for either you, Mark, or Paul. Can you talk a little bit about the differences between the different vaccines that are out there, whether they be the Pfizer, Moderna, Janssen, or Oxford vaccines, and the technology that's being used, whether people should be concerned about getting one versus the other, et cetera?
I'll start with so it's kind of an interesting story, because one of the reasons the vaccines have been developed so quickly is because this mRNA technology has come along, and you can rapidly take the mRNA, which they did, the mRNA to produce the spike protein of COVID, and they knew that that's sort of the Achilles heel of coronaviruses. And so that's mRNA, and the big technological leap was to put it in a lipid nanoparticle in order to make it stable enough. So anyway, that's one technology, and what that happens is it goes into the muscle cell. The muscle cell then is your protein factory. And so you rely on your actual own cells to make the protein, and it makes it correctly like our cells do all the time. And so that's how the mRNA works. So it presents the protein in the protein, and then the immune system basically recognizes it. The second technology is what's called recombinant adenovirus. And so the adenovirus is another virus that causes a common cold. What they've done is they've made it replication incompetent, so it can only infect one cell at a time. And so basically they're using this adenovirus as a payload, and again, they put the genetic material in there, in this case DNA, of the COVID, of the SARS-CoV-2 S protein, same thing again. And so then this thing then goes into the muscle, it enters the muscle via the adenovirus type mechanism, and then the DNA then gets made into RNA, and then that gets translated into the protein. Then the next technology I should mention is the ones that the Chinese have mainly adapted, because it's very easy to do and it's old technology, and that is to take virus, grow it up, inactivate it, and then use that as a vaccine. And that's what the Sinovac vaccine that's been used. And then the final technology I'll mention is what's called the recombinant protein technology, which is similar to what's been done for hepatitis B vaccine. And that is where you take the SARS-CoV-2 S protein genetic material again, but this time you make the protein in the test tube, and then you isolate the protein, you purify it, and then you use that as your actual protein. You inject it. So the protein's already made, but you have to make it in the test tube. And that can be somewhat tricky, and it takes longer, which is why the Novavax, we just now found about their efficacy results were the Novavax studies. But the latter type of manufacturing is going to be essential because it's cheaper and it's much more stable. So hopefully that will be able to be given to rest of the world because of that.
Maybe I'll go to Mark Wilson, and and Mark, if you want to defer this to someone else, that's fine. Should people be concerned about which vaccine they get, or which technology is being used for the vaccine they get?
Well, anytime in the near future, they shouldn't, because there's so little vaccine. You need to take whatever vaccine you get a chance to get. People won't be able to have the luxury to pick and choose. The Moderna and the Pfizer vaccines that are currently available are really pretty much identical in terms of their efficacy. The Johnson & Johnson vaccine that we anticipate may get approved as early as next week. It has a little bit less efficacy in terms of preventing infection with the virus, but it's still virtually 100% efficacious in preventing hospitalizations and death. And that's really the bottom line in terms of you as an individual, and how helpful it is for you as an individual. That's what we're mostly concerned about. So I think, as we go along, once the entire population has the opportunity to get vaccinated, maybe there'll be some choices people can make. But these are all really good vaccines. They're amazingly good vaccines.
And should there be any concern about the safety of an mRNA vaccine? It's a new technology, as Paul had mentioned. Is that a concern that people should have?
The safety data on the studies that were done was also incredible. Essentially both for Moderna and Pfizer, really no vaccine-related deaths. The main concern was this anaphylactic reaction that was discovered, but it's like 11 out of a million vaccinations where people have anaphylaxis. And even then, you can quickly treat that with an EpiPen. That's why we observe people for 15 minutes after they're vaccinated as a precaution. In terms of long-term effects, I think one of the main things people need to understand is when this mRNA enters your cells and does its job, it quickly disintegrates, and it's not getting into the nucleus of the cell and affecting it's not even coming in contact with your DNA at all. I know that when we've done some education with community members, showing people just a simple picture of the cell and making that one point, I think has been very reassuring to people in terms of any concerns about it affecting you long-term.
Okay, great, thank you. I'm going to transition now, maybe Dr. Kaslow, and ask you a question about, so if someone receives a vaccine and maybe 10 to 14 days later, should they still be concerned about getting infected? And if you can talk about that, and along those lines, what should people do? Do they still have to wear masks? Can they visit family members, et cetera?
It's pretty clear that what we have to do is break the question down a little bit into, is there a risk for symptomatic infection, which is what the trials addressed, or any infection at all, even asymptomatic? And then the third aspect would be, what about transmission of infection if you do get infected? So in the pivotal trials, of course, the main endpoints were symptomatic and severe infection. And in both the Moderna and Pfizer, the endpoint rates were trivial in a way. 8 out of 21,000, or about 0.04% in the Pfizer trial, had symptomatic COVID up to 4 months after their second dose. And in Moderna, it was similar. 12 out of 14,000, or about 0.08%, had symptomatic COVID up to 4 months after the second dose. So those were the findings, of course, in the context of a randomized controlled trial during the 4 months of follow-up in the locations where it was done. And those proportions could be higher or lower according to the person time of exposure over time, of course, and depending on the incidence in the community, the underlying comorbidities of the individual vaccinees, and whatever preventive measures were being taken at the time. So there are a number of variables that go into that estimate. Aside from the new and potentially vaccine-resistant variants, and that's of course a big qualification as to what will ultimately happen, the bottom line is that in 10 to 14 days after second vaccination, the risk of symptomatic infection would probably be a very small fraction less, or even far less than 1%, especially with our now pretty rapidly declining incidence. So as for any infection, symptomatic or not, 3 weeks ago, the Israeli Health Ministry summarized a very comprehensive follow-up of over 700,000 Pfizer vaccinees, where only 317, or again, about 0.04%, got infected 1 week or more after the second dose. There were no data from unvaccinated comparison groups, so it's a little difficult to determine what the relative protection was. But the answer is, for any infection, clearly no, unless the variants that are more transmissible or more virulent become more dominant in the near future. The concern about any infection is probably almost as low as it is for symptomatic infection. So then the question becomes the transmissibility, and we'll get to that in a moment. So the next question is, why are people who are vaccinated getting infected? Well, the variety of reasons. Of course, it's an imperfect vaccine. It's not 100% efficacious for symptomatic illness. It's not producing sterilizing immunity. And there may be logistic problems with cold chain issues that could have occurred randomly in a very small proportion, hopefully, of the mass distribution that's occurred. There are immunocompromising conditions that prevent people from responding properly. There's the community prevalence of infection. The higher the prevalence, the more likely anybody is to get infected. There's excessive personal exposure, which probably doesn't contribute very much, but it could in, for example, long-term care facilities or somewhere where there's happens to be an intensive exposure in a small space. And then there are the viral variants that we're now seeing more and more. And the final part of the question, I guess, is what about people who've been vaccinated in the 2 weeks or so afterwards? What can they do? Do they have to wear masks? And the answer is, well, for all of the above reasons that somebody may get infected, even though it's pretty small, the answer for now is yes. And I think as much for preventing transmissible infection, which you may not know you have, as much as to protect yourself after you've been vaccinated. That's the short answer. We can talk about that a little more if you want. Can people visit family members who've been vaccinated? Well, it kind of depends on which visitor and which family member you're talking about. I wouldn't want my 25-year-old grandchild from a high prevalence location who was partying for the last weekend and took 2 flights to visit me. I wouldn't be particularly happy about having him arrive here unprotected. Whereas somebody who quarantined for 10 days and maybe had a negative rapid test before he arrived and traveled alone by car would be a much safer risk. So obviously it's a question of the individual situation and what the risk might be. The important question is not what happens in 10 to 14 days, probably, but what happens in 10 to 14 weeks or 10 to 14 months afterwards. When will we start to see the waning immunity that we'll talk about later kick in, and we'll have to be concerned about what the risks is at that point.
Okay, great. Thank you. There's, I got a message in the chat box. Will the answer hold this the same for the Oxford vaccine too? In terms of a lot of what you're saying.
Well, I suppose that's going to depend on what we finally hear in terms of the results, the relative protection that you get. I think the Oxford folks are doing more detailed examination of infection versus symptomatic and severe infection, but I don't think the data are in yet, and I don't know what we're going to be able to conclude at that point. Paul, you may have some more information about that. I don't know.
Well, so the Oxford vaccine is kind of interesting. There are lots of facets to it. When they first came out, it had an efficacy rate of anywhere from 60 to 90%. And at first they thought it was this sort of half dose versus full dose scenario, but I think they've since sort of decided that the issue was that the half dose people, they waited to boost them for like 3 months, where the other ones were just 1 month, and they got a better immune response. So that likely explains the better efficacy. And then, of course, they did a really small study in South Africa, which is that variant that Dr. Kaslow was mentioning, the B1351 variant. And that one actually, it showed that it was just 22% effective. And so South Africa just completely scrapped the program for the AstraZeneca, but they went with Janssen. In fact, now they're doing a phase 3B study where they're vaccinating 500,000 healthcare workers in South Africa with a Janssen study, with a Janssen vaccine, I'm sorry. Because there, it's interesting, even in the setting of this variant, you know, the majority of transmission, the majority of cases in South Africa is this variant, this B1351 variant that's partially vaccine resistant. The vaccine was 57% effective against symptomatic COVID infection and 89% effective against severe COVID infection. So they thought it'd be a good idea to give them that vaccine. So ultimately, I think the US is going to rely on the US study, which is almost fully enrolled now in the United States, the AstraZeneca Oxford vaccine. And I think we'll have a better idea of the efficacy in the United States with that vaccine soon.
Okay, great. Thank you. Lots of points brought up, and there's some comments in the chat box that we'll get back to in a minute. I'd like to keep moving forward and ask Dr. Hidalgo about vaccine hesitancy, which seems to be mentioned a lot in the lay media, and whether you can provide us some guidance as to whether this is a real problem that we as public health professionals need to be concerned about. Are strategies being developed and implemented to address this? And how this may be addressed, especially for people of color, given racism that's existed and continues to exist in the US?
I'll address the latter point, which is that when people have approached me and others about being hesitant to get any of the vaccines, whatever they may be, whatever is available to them, that first and foremost, it's really important to acknowledge that they're right in feeling somewhat nervous or uncertain, right, about getting these vaccines, because we do have historical examples where populations have been taken advantage of, and that it's important to first make that step to say, yes, you're right. However, this is the data that we have available for the vaccines that are available to us in the US. This is what we know. This is how well they're working, as described by Dr. Gifford, Wilson, and Kaslow. But as we have seen in the media and the papers that have come out that are scientifically backed. And so I think being able to provide information to people that show them exactly what it is that they need to hear in order to make informed decisions for themselves. Because one of the studies that came out recently suggests that about 40% of people are willing to get any vaccine that's available to them when it comes out. There's another smaller proportion that wants to wait and see. So they're willing to get it, but they sort of want to wait for others to get it and see if people in their circle do okay with it. Then there are people who don't want to get it at all because they are either afraid or don't trust the science or what have you. And then there's even a smaller proportion that just feels that this is like some sort of attack on people and that there are trackers in the vaccine and so forth. And I think that smaller proportion is a very vocal and loud portion of the people that we're hearing on social media and that we're hearing in communities, but that is having somewhat of an effect. But when you look at the numbers, a large majority of people do want to get it. And so I think it's about the messaging that we put out there. It's about making sure that our messaging isn't confusing to people, right? A lot of people are hearing the vaccines are effective, but we still need to wear a mask after we get the vaccine. And I think those types of messages are often confusing to people. People don't understand exactly why it is that we need to continue to wear a mask afterwards. And there are a number of reasons why we should, right? Many of them we just talked about now. And so I think in thinking about how it is that we talk to people, that we change our mindset and our paradigm to actually talk with people about what exactly it is that they are feeling, what is being said in the community, so that we better understand how to craft that messaging, and that it's not talking to communities, it's not talking to people, but that it's having a conversation, so that we can better increase informed representation of people in the population.
Okay, great, thank you. Maybe I can follow that up with a question for Dr. Wilson and what he's seen in Jefferson County in terms of vaccine hesitancy, as well as issues surrounding implementation of the vaccine distribution to all communities.
Yeah, I think in terms of vaccine hesitancy among the Black and the Latinx community, we as a health department have started pretty early in doing some outreach, just some educational sessions with community influencers, pastors, neighborhood leaders. We have using primarily African-American and Latinx speakers and experts to be the spokespersons. I think those have done pretty well. Again, like Dr. Hidalgo said, we're just presenting the information, not taking an arm twisting approach, but just telling people we want them to be well informed. We're not the only ones doing this. UAB is doing a lot of work. A lot of physicians in the community or other health people in the community that have expertise are doing some of this on their own as well. So there's just a lot going on, a lot more to do, obviously, but trying to have as many conversations as we can with people to make sure they're well informed. There's plenty of demand for vaccine right now, way more demand than there is supply. So it's frustrating for everyone right now, but it's sort of a good problem to have. I mean, I think we're not seeing as much vaccine hesitancy as we were first concerned about. And of course, a lot of people that initially declined to get the vaccine wanted to take a wait and see approach. A lot of them now are saying, no, I want it. But in terms of equity and distribution of vaccines, the vaccine allocation plan that the state has, is pretty closely following CDC recommendations. But there are plenty of people who disagree with that, especially younger people who have underlying health conditions, saying that they have a long time to wait still. That's been very frustrating. The allocation of vaccine is very centralized. The state health department is deciding which entities get vaccine and how much they get. It appears to be pretty equitable among the different counties. And the percentage of people in each population, each county that has been vaccinated so far is fairly evenly distributed. It's not totally perfect. But you do hear stories, about, well, how did so-and-so get a vaccine in another county when they're not available in this county? And I think, I don't have exactly the right answer to that, but I think some of it is the fact we have so many healthcare workers in Jefferson County that 1A group, that first priority group, was a lot of people and used a lot of vaccines. So once we moved to the 75 and older and the 1B and then the 65 and older, it's just a huge number of people that are now eligible with very little vaccine relative to that number of people. So it's just, our main message right now is, it's going to be frustrating, y'all. It's going to be a long wait. Just hang in there, keep trying. We, as a health department, we're not coordinating things locally. It's all, like I said, being coordinated centrally. We are, however, trying to help inform the state health department what we're seeing here on the ground, advocating for groups that we know are dedicated towards serving the underserved populations in the community, and some that are, healthcare providers such as our federally qualified health centers that are located in low-income communities to make sure they get vaccine. But the approach from the state has with the exception of these mass vaccination sites that were sort of stood up temporarily at 8 different sites across the state, UAB being one of them down at the Hoover Met, which was intended to serve the region, not just Jefferson County. That was a temporary surge with some temporary excess supply of vaccine. But going forward, it looks like more and more it's a sprinkle it around sort of approach with multiple providers, multiple access points spread around, rather than an approach where you have big centralized mass vaccination sites. So I think to some extent that makes it more inefficient, but in Jefferson County, I can say that we have way more capacity to vaccinate, and we're able to push vaccines out pretty quickly. So I don't think the inefficiency is a really big deal here. The main issue is just simply the supply.
Okay, great, thank you. We have a question, and maybe I'll ask Dr. Hidalgo, but others can chime in as well, because it's really about communication. Would you recommend interacting with people who are, I guess, anti-vaccination, or is it best not to engage with them at all?
Yeah, I saw that question pop up, and it's an interesting one. So in my experience, I do engage with people who seem genuinely concerned about things that they have heard, right? When we first heard about the Pfizer and Moderna vaccines, there were rumors, and they still are circulating, that the vaccines cause infertility, for example. There are rumors that that the vaccine uses tissues from aborted fetuses. There are rumors that, like the most extravagant, obviously, is the microchip rumor. And so I think there are explanations, and understanding where the source of the rumor is, or what the rumor is really important in your conversations with people. So, for example, someone on a Reddit board said that the spike protein looks a lot like the syncytin-1 protein that is involved in like placental development, and that the antibodies that are going to be created in your body when you get the vaccine are going to mistake the syncytin-1 protein and therefore like attack your placenta if you're a woman, and it's going to cause disruptions of pregnancies and like for future fertility and so forth. It's a lot of time that is spent trying to research some of these topics in order to get to the bottom line about yes or no, this is true or false. But sometimes it's important to have those conversations with people so they understand where the source of the information is coming from and what the actual information is. So it depends answer, unfortunately. I think some people it's worth going into with, and other people you're not going to be out there to change minds. Your goal in science communication is going to be to provide the facts and hopefully allow people to be empowered to make informed decisions for themselves and their loved ones.
And there's a great question in the chat box, which I think there are a few more that I'm jotting down, but I'm going to go back to some of the pre-planned questions, and this will be for Dr. Kaslow and maybe Dr. Gifford as well. And this is a question about how long vaccines will last. Will they provide lifelong immunity? Do you think boosters or annual vaccines will be needed? And if so, how will these be developed? Will randomized trials be needed? Or is this going to be set, and will this be similar to the annual flu vaccine, where this is going to be happening, on an annual basis? We'll get a COVID vaccine.
Well, for me personally, the concept of lifelong immunity is good news and bad news. The good news for someone my age is that achieving lifelong immunity would involve a sprint and not a marathon. But the bad news, of course, is that at my age, my immune system may not even be in shape for a sprint. that's sort of an introduction to the whole question of how long does it last? Right now, the longest we know protection lasts is the interval since the trial enrollees got their second dose, which was back in August of last year, about 5 months ago, and maybe a little longer if we accepted the immunogenicity data from the phase 2 trials. But we're still talking about a matter of months in which protective antibodies do wane. The question is, how low can they go? We'll talk about some other aspects of protection in a moment, but it's not in a non-negligible proportion of vaccinees to the extent that we understand it at this point. But the degree to which that represents a true loss of protection against clinical illness is not yet entirely clear. We know durability of antibody response in general varies among individuals, of course, for a variety of reasons, and that surely will apply to the COVID vaccine as well. There's also a difference between conventional booster and annual vaccination. The difference isn't entirely semantic. Classically, doses for primary series are given at short specified intervals, such as the vaccine we're getting now, which is a 3 or 4 week interval. Later boosts use, in a matter of months or sometimes even years later, use the identical product as we do, for example, with measles or polio. But for influenza, as we all know, the content of the immunizing agent is altered annually according to the seasonal drift or shift that occurs, the evolution that happens in the virus, as we may be seeing now with SARS-CoV-2. For this virus, the flu paradigm appears to be increasingly more likely. Moderna is already evaluating whether boosting with the original vaccine generates neutralizing antibody beyond that they saw in the clinical trial, the highest levels. They're also testing a vaccine with a modified target to the South African B1351, and similar efforts are underway with other manufacturers as well. In other words, the manufacturers have already accepted the likelihood that repeated vaccination is going to be needed, although the composition and the frequency are obviously not predictable. So how will the boosters be developed? Paul may want to comment on this, but in general, I would say ideally the vaccine would stimulate broadly neutralizing antibodies and long-lasting memory T cell immunity if it could, to protect indefinitely against most or all of the viral strains that may develop. But more immediately, we may have to really settle for a multi-component product. And fortunately, both the mRNA and the viral vector-based platforms make that readily adaptable to the changes in composition that we're seeing occur with the variants at this point. As for the need for further randomized control trials, discussion, I think, is now more along the parallel with the annual flu vaccine model and not requiring large-scale trials. Small phase 1 and phase 2 trials of a few hundred subjects could probably exclude some of the frequent but unexpected adverse events that might occur, and they document levels of neutralizing antibody that are equivalent to those shown to be protective in the original trials. So I don't think that's going to be a game changer in terms of needing long-term, large RCTs. Especially if the variants do appear to escape from immune control, the urgency to get modified products into the population would probably preclude large, long-term trials anyway. And the FDA and the other review groups would undoubtedly be under enormous pressure for at least emergency use authorization, if not formal approval. I don't know, Paul, do you want to add to that at all?
Well, you've said a lot.
Too much.
I can add a couple of things. If I were to predict, I think we're going to need boosters. I don't know the timing, and the reason for that has to do with variants. We already know that vaccines don't work as well against variant. The Novavax and Janssen both have data on this. So Novavax studied it in the United Kingdom, where you had the the B1171 variant, which is the one that's highly transmissible, but not neutralization resistant. And in that setting, it worked about as well, 90+% efficacy. Then they tested it in South Africa with this resistant variant, and it was only 50% efficacy. Janssen, I mentioned already, was 72% in the US, where you have the sort of the wild type strain, if you will. And then in Latin America, 66%, and in South Africa, 57%. And those are all areas of the world with sort of increasing variants, neutralization resistant variants, if you will. And then a couple of other things. Dr. Kaslow rightly mentioned that the best data is really long-term vaccine efficacy data. And so we do have antibody data from Moderna, and it does wane a little bit, but that assumes that antibodies what's efficacious. We just don't know what's the efficacious component. So we need to continue to follow up participants in studies. And to that end, there's Moderna, Pfizer, and now Janssen are all planning crossover studies. And so the people who didn't get vaccine, whatever, 4 to 6 months ago, will now get vaccine, and then they can actually see if their efficacy has declined. The people who originally got that vaccine, if their efficacy declines compared to those who just got the vaccine. So we will have that data. I don't, as Dr. Kaslow said, we just don't know right now, but I think most of us are predicting that we will need some sort of immune boosters in the future.
Okay, great, thank you. So a question came up in the chat box about testing the vaccine or the vaccine availability and safety for pregnant women. I'm not sure if someone wants to talk about that or has knowledge enough to talk about that question.
I mean, my wife's an obstetrician, so I guess I could talk about it.
Okay, great.
But to be serious, though, for a minute, none of these vaccines have been tested in pregnant women, and because they're exclusionary, and that's just a traditional way of doing things. We don't want to test the product in the most vulnerable to begin with. However, most major medical organizations have endorsed that pregnant women can get the vaccine if they discuss it over with their primary care provider or their obstetrician. And the reason for that is because there aren't any theoretical reasons that it should be problematic in pregnant women and lactating women, I should say. And then also, as you know, women are at high risk, pregnant women are at high risk of severe COVID complications. And so right there, I think it becomes a risk-benefit sort of discussion with each pregnant woman and their obstetrician. But most of the medical societies have endorsed that pregnant women can get the vaccine.
Okay, great, thank you. Dr. Wilson, I had planned to ask a question, and maybe I can ask this to you, but I'm going to ask it in 2 parts. The question I was going to ask was COVID as a global health issue, and whether it be vaccine distribution around the world, and whether that's something that you feel like should be supported, or whether you feel like that'll take vaccines away from the US. Along with that question would be the ability to get vaccines to the rural areas of Alabama. And I'm not sure if you can comment about that, either of those questions.
Yeah, it's a really tough question about the world, beyond my pay grade for sure. But I think, it's really hard because we're in such desperate shape here in the United States. I mean, we've had more cases, more deaths than anybody. And so I think we're very anxious to get out of this situation. I think beyond that, it makes a lot of sense to support efforts in other countries because none of us are isolated. So just from a sheer standpoint of keeping the disease under control, we have to make sure that we have global vaccination. A lot of justice issues and equity issues there that are just really tough. And, I think everybody's so desperate right now, they're grabbing what they can. In terms of here in Alabama and rural areas, the Johnson & Johnson vaccine would be really ideal for areas that may not have the freezer capacity, things like that. But I'd say pretty much in every county, the vaccine using, if not the Pfizer, using the Moderna, the vaccine is getting out. The distribution, as I said earlier, is looking pretty even. So we're managing to do it using healthcare entities and public health departments to get the vaccine out. But I do think it'll play an important role in terms of getting it out to more remote areas. I think one strategy that's looking like it will work really well is to use churches and communities to host vaccine sites. We're starting to do a little bit of that in Jefferson County, but in the rural areas, I think that's going to work really well. But in talking with the state health officer, the state health department, it's been a few days since I've had this discussion, but at this point, I don't know of any particular plan on sort of how to use the Johnson & Johnson vaccine, how it will fit into the grand scheme of things, or whether it'll be a particular targeted entities that will get it, or if it will just sort of be sprinkled around with everything else. So we'll see.
I think it brings up an interesting point. I've just added, because as you probably know, the Johnson & Johnson vaccine has much easier storage requirements, and it's one shot, and it may be more amenable to rural areas. But then I worry that then the rural areas will start thinking that, well, you're giving me a vaccine that's not quite as effective against preventing COVID, symptomatic COVID, than the Pfizer vaccine. So it'll be interesting to see how that plays out.
And that's been a discussion already in the African-American community here, just this thought that, oh, we're going to be, people are just saying they can predict we're going to get second best. So that's a tough conversation. We're starting to work on getting some of the homeless population vaccinated. So I think in terms of homeless people, transient people, folks that you may only have one opportunity, and then you might have trouble tracking them down, then it'll be ideal for that.
So we have a few more questions. I just want to be cognizant of the time, so everyone has a break before their 1 o'clock meeting, if they have one at 1, or class. So the CDC recently changed their quarantine guidelines for fully vaccinated people. This is in the chat box. Do you anticipate more guideline changes after more people become vaccinated?
I would say, in terms of communication, what people need to understand is that this is obviously an evolving situation, right? And so as the science and the evidence changes, we need to change the guidelines and recommendations. And so that's really hard to come to terms with, because as a society, we're so called to be binary thinkers. Yes, no, right or wrong, dead or not dead when it comes to COVID-19. And so I think it's really important to have a flexible mindset in terms of what we're hearing. So yes, the short answer is yes, there's likely to be changes in communication as the science changes.
Okay, great. A question for, I'm not sure who this would go to, but is the US doing enough monitoring to understand the spread of existing mutations, and more importantly, to recognize new mutations?
Maybe Dr. Kaslow can.
Well, the short answer is no, not at the moment, but there is a push. I think the Biden administration just announced a pretty large infusion of funds to dramatically increase the amount of sequencing that will happen all over. So depending on how fast that happens, we will hopefully get up to speed, but the answer is probably no at this point.
Okay, great. And the last question I have here is, in your experience, and this can go to everyone, in your experience, how can the School of Public Health prepare students for what public health will look like in later this year, 2022 and beyond, in terms of what courses should students be taking, and what field experiences may be most helpful, given this is an important time for public health? And maybe Dr. Wilson, from the Department of Public Health perspective, I'm not sure if you see needs that future graduates from the school will be able to fill to help battle pandemics or other public health issues in the future.
Yeah, I see Dean Irwin looking straight at me. Yeah, I think one thing that's really been interesting in this pandemic, which everyone's aware of, is it's really a lot of it is the human behaviors and the sociology, the psychology of all of it, and unfortunately the politics. And I just sort of feel like we can follow the science, we can make recommendations, I can issue orders and things which do have some effect, but at the end of the day, people sort of do what they're going to do. And so I think that's been a real challenging thing for us during this pandemic, is sort of having a deeper understanding of those behaviors and what motivates people. And certainly communication, how to do effective communication to the public. I'm not sure I've always gotten that right, but that's just really been a huge challenge to this pandemic, probably more than any of us anticipated. I mean, we have had actual discussions here about, do we do some other restriction, or do we crack down on this non-compliance here or there, and we, there's several times we're close to having just a rebellion on our hands. Parents not telling the schools that their kids are sick because they don't want them to be quarantined. And at some points making real big compromises based on that, because we know that if we're not careful, we'll just lose our public altogether, and then we can't do our work. So I just think that's one big area. I don't know which particular course that is, but having some understanding of that, I think is really important.
Okay, great. Any other thoughts on this, Dr. Gifford, Hidalgo, or Kaslow?
It's an impossible to get it exactly right, it seems to me. I don't envy the school boards, the teachers, anyone who's involved in this decision. It just seems no matter what you do, it's going to be wrong at some level or another.
Okay, great.
Sorry to be that pessimistic, but
I do think that, everything's happening so rapidly. We kind of want answers right away,
right?
Even though everything's happening rapidly. I think the situation may evolve, hopefully for the better, over the next following months, and we'll have a better feel for exactly how to do this. But I agree, you're going to make somebody mad no matter what you decide in that situation.
Okay, well, we're at the top of the hour, so I'd like to thank our discussants, Dr. Gifford, Hidalgo, Kaslow, and Wilson, for a very great discussion. I'm just going to give you a virtual round of applause. And, thank you very much. And thank you everyone for joining today. And I hope everyone has a great day and a great week.